All right, so let's talk about endocrine, or at least the pancreas stuff. This is like those 10 pages that are in the other chapter, chapter 13, okay? This one, I guarantee there'll be questions on the test. When I say test, I'm talking about my test, my final exam, and NCLEX, all right? I bet you everybody here, if you're not a diabetic, I'm sure someone here knows someone with diabetes. So there's a lot of questions you'll need to know about this. So let's get started with a little bit of this. All right? Okay. So you know about insulin. Insulin, let me first explain to you, and this is a little bit of review from A&P, because I need you to really understand this for me to talk about the diseases. How does insulin work? How does glucagon work? Okay, glucagon is going to, if your sugars in your blood are very low, then glucagon is going to go to glycogen in your liver and muscle and has these big, in your liver you have these big icebergs of glucose called glycogen. And glucagon is going to chip away at that glycogen and put little pieces of glucose into your bloodstream. Okay, so that's what glucagon does. All right, so if your glucose in your blood decreases, that's going to increase glucagon. And that's going to increase glucose in your bloodstream. Okay? So that's going to keep on going up, keep on going up, keep on going up. If it goes too high, then that increase of glucose is going to make the pancreas secrete insulin. So this is what insulin does. If outside the hallway is your blood vessels, and you're inside of a cell, so there's your blood vessel, and you have people and students out there. The students are glucose molecules. Now, the door is closed. Okay? So the students out there, they're multiplying. They're getting not multiplying, but there's more of them increasing. All right? There's more of them increasing. People are walking in and stuff. So the hallways are getting filled. Okay? So now you have hyperglycemia. You got too much glucose in the bloodstream. And we're going to talk about what is high glucose going to do. Hyperglycemia is going to actually ruin the wall. If you have too many students out there, they're going to start damaging the walls over there. We're going to talk about that. See where I'm leading with all of this, right? So we got to get some of that glucose out. We got to decrease the amount of glucose that's out there. So insulin comes out. Insulin is what the security guard has, a key. The insulin key. Now, insulin doesn't come inside the cells. No. Insulin unlocks this door to allow the students to come in to the cell. What does that do to the amount of students in the hallway? Decrease. So insulin is going to decrease glucose in the bloodstream. Okay? That's what insulin does. And then the door will close. Then the insulin will come off, and then, we have to wait until. Then there's no one out there. Then we got to get more students. We got to go to the registrar and see how we can get enrollments. We get more students there, and so that's glucagon. Glucagon is another story that is all about the registrar, okay, and admission. But that's what's happening over here. We understand how insulin works. It's a key. It just unlocks the doors. That receptor that the key goes in is the keyhole. And we're going to get back to what that is because that's all about diabetes. Okay, so if you have too much insulin, that means the doorway is always going to be open. So whatever student's out there, they're always going to come in. Does that make sense? So your sugar that's out there is going to go very low. So the most common cause of this is iatrogenic. Someone gave themselves too much insulin. You're supposed to get 8 units. They decided to give themselves 12 units. So now they open up all the doors. And then the sugar just goes down. And we need more sugar out there because it needs to go to other places, but there's no more left. The other thing that can happen is something called an insulinoma, which is a tumor in the pancreas that's going to produce a lot of insulin. So if you have an increase of insulin, you become hypoglycemic. That means there's going to be a decrease of glucose into the cells because there's less out there. You're going to increase your sympathetic nervous system. See, I want to teach. Because there's no students in here. The door's open, but there's no one in here. So I start getting nervous. I want to teach. I can't do that. So my sympathetics kick in. My fight or flight. I start sweating. I start getting frantic. Right? I start getting nervous. My heart rate is going faster. That's what's happening when you have a lot of insulin. It can cause confusion. Eventually go into coma. You see, the brain only can use glucose for energy. The other parts of your body, they could use other things. They could change amino acids, like gluconeogenesis, right? You want me to go through that? Okay. But gluconeogenesis, you can turn fats into energy. You see what I mean? You can do it. But the brain can only use glucose. So if there's no glucose in the bloodstream, your brain shuts down. It goes into a coma. So we have adrenergic, well, there's a nice word, adrenergic effects. Adrenaline. It's all those things, the fight or flight, the sympathetics kicking in. Anxiety, sweating, hunger, headaches, tachycardia, tremors. But you also get a neuroglucopenic. What does that mean? Break it up. Neuro means nervous system. Gluco, sugar. Penic. Remember thrombocytopenia? Penia is a decreased amount. So this is a low level of glucose in the brain. What side effects do you get because of this? Confusion, slurred speech, seizures, eventually coma. Okay, so you have all these different symptoms that happen because of this high amount of insulin. Okay? Questions on that? All right. Let's talk about diabetes. Okay? So we have a deficiency of insulin. Now, this is the key thing. All right? Diabetes mellitus. All right? Number 1 endocrine disease. Number 1 risk factor for coronary artery disease. Number 7 killer in America. Okay? You need to know about this stuff. What happens here is that if you have a decrease of insulin, your glucose in the bloodstream, the students in the hallway, will increase. The doors are closed. We call it hyperglycemia. The glucose can't get into the cells. All the results of all the symptoms and signs are all based off of hyperglycemia. Okay? The major cause of all the symptoms. Now we have acute symptoms and we have chronic, long-term and short-term. Some of the short-term ones, the things that happen relatively quickly, since you have all the sugar that's all over your body, it's in your teeth, it can't get absorbed, they're going to start rotting away your teeth. They're going to get a lot of cavities. You're also going to get, your immune system is going to go down, and you're going to have infections. You have a lot of glucose that's in your bloodstream. It has an osmotic effect to it. So if you have a lot of glucose in there, it's going to draw the fluid from your interstitial area into the bloodstream. Right? It's osmotic or oncotic pressure. If it does that, it increases the blood volume in your blood vessels, which means you're going to have hypertension. You're also going to get ketoacidosis. We'll talk about that in a little bit. Okay? When you go back, you see it. So these are very relatively fast kind of things. But then we have a whole slew of chronic stuff. You get peripheral vascular disease. Because what happens here is that the glucose becomes very sticky. It's sugar, but it's sticky. And it sticks to the walls of your blood vessels. But it also combines with another thing that we're going to talk about later called LDLs, or low lipid protein, low lipoprotein lipids. No, I'm sorry, low density lipoproteins. Sorry, LDL. Yeah, I know. Low density lipoproteins. Okay? They mix up with that and they start going in the walls of the blood vessels, and the blood vessels become inflamed because of this. So now the blood vessel walls are going to get thicker so much that they're going to cut down on the blood flow that's happening in those areas. So now less oxygen, less nutrients are going to go to certain organs. So you start having this peripheral vascular disease in your legs. It starts hurting because you can't get blood to go in the right places of your muscles. You get coronary artery disease. The coronary arteries start clogging up because of all this extra glucose. Stroke, right? Same thing going up to your brain. Retinopathy. This starts affecting the blood vessels in your retina. You go blind. Nephropathy. That's kidney. Nephro means kidney. Apathy means disease. So you start getting the kidneys start affecting. It starts less blood flow going to the kidneys themselves, and the kidneys start failing. It starts turning more sclerosed or more scarred. And we call it nephrosclerosis. And 20% of diabetics get kidney failure. They have poor wound healing. It takes a long time for all the oxygen and nutrients getting to that area that you just had a cut on. So now it's going to take, like, normally if it would take you 4 days to heal, it might take you 2 or 3 weeks to heal. It causes gangrene, and eventually you have to amputate it because now it gets infected. Neuropathy. They step on things like a piece of glass and don't even feel it because the nerves, the blood vessels are we call it microcirculation. The small blood vessels to go to your nerves are affected. So now the nerves start dying down because it doesn't get all these nutrients it's supposed to get. So they start dying down and you don't feel. So they have a decrease in sensation, and they have what we call the diabetic foot. All right, you get the gangrenous foot. So if a new diabetic is newly diagnosed, they don't just get one doctor. They're getting a slew of doctors. They got to see the optometrist that's going to take care of the eyes. You got to go to the kidney doctor to make sure that's okay. You got to see your heart doctor. You got to go see your podiatrist. I mean, you get a whole slew of doctors, let alone nutrition and diabetic teaching. Oh, there's a whole mess full of different people involved in this. Okay? So on here, I took this from your textbook. This is showing you what happens when the glucose, the high levels of glucose in your bloodstream mix with the LDLs. It goes inside, they're called foam cells. They go inside the walls of the blood vessels and start filling up over here. So now the blood is not able to get through this. It gets occluded. It gets stenosed. There's less blood flow through here because it starts filling up there. This is a normal kidney. This is nephrosclerosis. Notice the size of it. It's got smaller. Again, they get renal failure. 20% of diabetics get renal failure. Now, some early signs on this of diabetes. Hyperglycemia is there, okay? But what happens is, since there's so much glucose in the bloodstream, the kidneys get overwhelmed with all this glucose and can't reabsorb it all. So now it goes out in your urine. Now, you should not have any glucose in your urine. But in diabetics, you do. And for every molecule of glucose that goes out in your urine, 1 molecule of water goes out. Well, there is a copious amount of glucose going out your urine, so they are going to pee a whole lot. So they're going to have glycosuria, so glucose in the urine. They'll have polyuria. They're going to have a lot of urine going out. And because of all that water that's going out in your urine, well, you've got to replenish all this, kicks in, and you get thirsty. So now they get polydipsia. Now, one other thing about this diabetes is this. Doors closed. Students are out there. All your glucose is out there. In here, there's no one. I'm here. I want to teach. hungry to teach. I can't, there's no one in here. So what happens is that I send a message to, I don't know what's going on outside. All I know is that right now there's no students in here. The door is not open, but there's no one in here. So I call up admissions and say, hey, or the brain, and say, look, I'm hungry to teach down here, but there's no one in here. I don't know what's going on. It's supposed to be time to teach. So the brain says, you know what? I don't know what's going on either, but I'm going to be kind to you. I'm going to make our guy hungry. Maybe that's the reason why you're getting no students in here, is because maybe there's just low enrollment. So I'm going to go get more students. I'm going to get you more hungry. So that's why diabetics, they eat more, they're tired because they can't get the glucose in here, but the glucose is making their sugars go up in the bloodstream because they continue to eat. They have what we call polyphagia because they can't get the sugar in here. We don't know why, or the brain doesn't know why. So it makes you more hungry. Does that make sense? Right? So you could do all the steps over here to understand why you get polyuria, polydipsia, polyphagia. It's step by step over here. These are also signs and symptoms of diabetes. Things we just talked about and different things on here. So there's three types of diabetes. Okay, three types. There's one called gestational diabetes. Gestational diabetes is diabetes during pregnancy. Okay? Now sugar normally would go up in pregnancy anyway in the bloodstream. All right? So normally, and it's not that much, it kind of caps off, but we need to make sure that we're not going to put all the glucose into mom's cells. So the receptors for insulin are going to go down a little bit. It's not going to be so sensitive. It'll be lower because that'll make more sugar stay in the bloodstream, which means the more sugar will go to the placenta to go to the baby, which needs to grow. But the problem is in some pregnancies, the receptors for insulin get really turned off. It goes beyond what it's supposed to. And now the sugars go really high up. And in that case, they will get diabetes during their pregnancy. And that's called gestational diabetes. 20%, this is key, 20% of the women who have gestational diabetes become diabetics themselves later on. Once the placenta comes out, the gestational diabetes disappears. Because the source of where that stickiness of the receptors are, the insulin, is coming from the placenta. So once we remove that source, it goes right back to normal. But we do notice that gestational diabetic women, later on in their life, 1 out of 5 of them actually become diabetics themselves. So this is a risk factor for diabetes for themselves. We also have type 1 diabetes, not gestational, just regular. And in this case, this is an autoimmune disease. What happens here is that they are producing autoantibodies to destroy the beta cells of their pancreas. Remember, the beta cells is what makes insulin. So they destroy them. So these people don't make insulin. So these people are going to have to be on insulin all the time. We call it insulin-dependent diabetics. So this is usually young people. You know, like they usually get diagnosed when you're 15 or 20 years old, something like that. Okay, and that's what happens. So they need insulin. They usually have this diabetic ketoacidosis, which I'll talk about later. But that's not as common. That's about like 10% of the diabetics. But the more common thing is what grandma's got. Okay, what grandma's got is type 2 diabetes. In this case, what happens here is that this is what's happening. The insulin receptor over here has gunk on it. Here's a medical term. Gunk. Okay? So it's super glue, silly putty, whatever. There's something in there. So they have insulin, but the insulin key is not working. It's stuck. There's something, you can't get it in there. So in that case, the insulin receptors are insensitive. All right? We call it insulin resistance. They have insulin, They just can't, the keyhole or the receptor just doesn't work. Okay? That's 90% of the cases. What causes this is obesity. What actually causes all that gunk, the silly putty, the super glue, is adipose tissue. So what happens here, the more adipose tissue you have, the more gunk goes on there, which makes it more difficult to get the insulin to work. Does that make sense? So here's the vicious cycle. The vicious cycle is that food, you can't get glucose into the cell because you have too much gunk there because you happen to be too fat, okay? What happens now is that makes the brain say, well, I don't know why you're not getting glucose, but we'll make you more hungry. Like I said before, polyphagia. So now he's going to eat more, but that's going to make him fatter. It's going to make it worse because now there's going to be even more gunk on there. So it's a vicious cycle, on and on. And that's what's happening. So 80% of people with diabetes are obese, okay? The risk factors here is age, of course, obesity, and family history. So if mom and your brother have diabetes, there's a good chance you have diabetes or are going to be getting diabetes. Okay? This is a nice chart to put together with type 1 versus type 2. Okay? Type 1, we refer to it as insulin-dependent diabetes, IDDM, whereas type 2 is the non-insulin dependent diabetes, NIDDM. We usually see young people getting this, like 15, 20. The oldest I've seen was about 32 years old. This one, the type 2, we usually see like 40 years old, 40, 45, 50 years old. Okay? So those were what's happening. Now let's talk about, so let's talk about this diabetic ketoacidosis that I've been talking about, okay? The DKA. Now we mentioned a little bit about this when we dealt with metabolic acidosis, if you remember, but like I said, I'll tell you about it later. Well, here's the later, okay? Now, this is really fatal, okay, if it's not treated immediately. We usually see it in type 1 diabetics. You've got to really have no insulin for this to happen, okay? So type 2, very rare occasions it can happen, but it's usually a type 1 diabetes that's doing this. So this is what's happening. Here's someone with no insulin, okay? So therefore, if you have no insulin, there's no glucose going to the cells. You okay with that so far? Right? If no glucose goes into the cells, the body has to find other sources to get energy. So it starts breaking down fats. Now, when you start breaking down fats, that's okay, but the thing is that if you start breaking them down, you have an exhaust. You have byproducts that you just don't want. They start accumulating. It's like you're putting gasoline in your car, and it makes the car run. You can get from here to Florida, whichever, but you have a lot of exhaust coming out, stuff that your car and you don't need. Well, the side effect of this is that as the body breaks down fat, it's going to produce these, what we call fatty acids, which is what you need, but your liver is going to convert them into ketones. Now, ketones eventually be what we call ketoacids. And these ketoacids are these byproducts that are going to go into the bloodstream, and it's going to change the pH of your blood. It's going to decrease the pH in your blood, and now there's a lot of enzymes that's in your bloodstream that are going to soon not work because it's now in an environment that it's not suitable for it to work. They start breaking down. Remember, enzymes are proteins. If it changes if the pH changes, then these proteins are going to denature. They're going to start breaking down, and you're not going to be able to do normal reactions that your body does, and it actually will cause the body to go into a coma. This is life-threatening, okay? Now, a few things about this that are key, so you can pick these up pretty fast. Someone where the body is producing a lot of these ketones, what I usually see is if someone's lying on the ground, because they're usually comatose, they're like lying on the ground unconscious. How could I decide if they were hit on the head or they have DKA? I go up to them and assess the ABCs. I smell something on the breath. Their breath is so distinct, it has this fruity, nail polish kind of smell to it. Can't miss it. Absolutely can't miss it. So this is something that if you know you're a nurse or nursing student and you're in the hospital and you heard that someone has DKA, just go over there. you have the access to actually see patients and stuff, go over there and just smell that. Because that can save a life. You can actually see something, and you know exactly what the person has. Like just that smell, there's nothing else to smell. I can't reproduce it for you. Just, you will know it when you smell it. They'll also have a very distinct kind of breathing. Because they have so much carbon dioxide and keto acids that's got to come out of your body, they have these what we call Kussmaul's breathing. They're very deep and rapid. But they're unconscious. You'll see their whole chest go in and out very fast. And if you smell that, you know what's going on. You know exactly that person's a diabetic. Okay? You'll also have a lot of fluid and electrolyte imbalances because of all these ketones that are going in there. So this, you just do on your own. It's basically how ketone bodies happen, how these keto acids, how the acid changes, and how it can actually lead to death. Okay, so you get to look how to do that. This we kind of did with you before, right? This is that wonderful reaction. Water plus carbon dioxide will make carbonic acid. That'll easily be broken down to acid and bicarbonate. Right? But now what we're doing is, in keto acids, they're going to produce a lot of hydrogen ions, acid. So now this is going to go skyrocket up, the reaction is going to go this way, and we need to blow off a lot of CO2 to get the acid back to what it is, or at least the pH back to what it was. So that's why they have that breathing, Kussmaul's breathing, to try and get all that carbon dioxide out. And they'll keep on doing that until the pH goes back to normal. But because you're in DKA, it won't go back to normal unless there's treatment going on. So it's very distinct that you can see this. Okay? So that's DKA. And these wonderful people all have some sort of diabetes. Okay? So how do you diagnose diabetes using blood tests? Okay, so these are three things you should know, okay, in terms of blood tests. And you should know the numbers. Maybe a nurse, you should know these numbers. First off, you can do a fasting blood glucose. This is where someone doesn't eat or drink anything for 8 hours. If we do a blood test for that and it's less than 100, normal. But if it's between 100 and 125, that's what we call borderline. Some people call it pre-diabetic. But if it comes back as like 150, just think about that. If less than 100 is normal, and you haven't eaten anything for 8 hours, why would your sugar be 150? It wouldn't make any sense. Unless you're diabetic. Unless the sugar, the students out there can't get into the cell. You know what I'm saying? Right? So if it's greater than 126, it's got to be diabetes. Okay? We also do this. Postprandial. Prandial means meal, eating. Postprandial means after eating. 2 hours postprandial means 2 hours after eating. So you eat a meal, and then 2 hours later, we check your blood sugar. If it's less than 140, it's going to be higher than fasting because you just ate. That's normal. But if it's greater than 200, your body has to adjust. That's way too much. Okay? So that's where we do those 2 hours on there. The other test that we also do is something called hemoglobin A1C. Now this is a relatively new test. When I say new, we're talking about in the past like 20, 25 years. This is a test that we realize that if your glucose is so high in a person's blood, it starts sticking to your red blood cells. And this is a test that we can actually see what your blood sugar has been like for the past three months or so. So it sticks to the red blood cells, and it doesn't come off. But the red blood cells only last for 120 days, so the red blood cells will break up anyway. So this is a test that we can actually see what your blood sugar is like. Now, if it's less than 5.7%, that's normal. You're going to have some glucose in your bloodstream anyway, that's normal. But if it's greater than 6.5, that's not normal. It's a very tight window. So you got to keep up with that. That's very tight. From 5.7 to 6.5, that's tight. So that's how we can do that, is we use this. If a woman or a man is diabetic, and they come to us saying that this is what my sugars are like for the past week, and they all look good. I don't know if they just fudged the numbers, or if really they just had a good week, but I need to know what's going on for the past 3 months. So I'll do a hemoglobin A1C. And if it is, let's say, 13, that's pretty high. That may cause like a toe to come off, okay? So that's like double. So that's what I'm saying is it tests to see what your glucose level was like for the past 3 months. And there's some talk about this, that this is going to be a better predictive value than fasting or 2-hour postprandial. That they're now they're leaning towards that this is going to be the reason to diagnose someone to have diabetes, okay? So keep an eye on that. If it's not going to happen next year, it may happen next couple years, okay? All right, and treatment for diabetes, for type 1, they need insulin. You can't go get away from it. You've got to give them insulin because they can't make any insulin. It's an autoimmune disease that destroys the beta cells, okay? And diet and exercise will also help too. In type 2 diabetes, which is 90% of the cases, diet, weight loss, and exercise. Then, if they need it, if the diet's not working, then they might have to get some kind of oral hypoglycemic medication that's going to increase the amount of insulin coming out of the beta-HCG, out of the beta cells, okay? Then, you might have to give insulin. Now, why does that happen? Okay. Doors closed, okay? There's a lot of gunk on there, as I talked about before, a lot of super glue or whatever's on there. So the receptors are insensitive to insulin. So the security guard comes here, he's trying to unlock the door, he's having issues. He's the insulin guy, right? So what does he do if he does that? If he can't put it in there, what's the next thing he wants to do? Call backup? Hey guys, I'm having trouble opening this door. You have some more insulin keys over there. I need you guys to come over here. Now, when you have a person bringing over 10 insulin keys, there's a greater chance that they're going to be able to open it, right? You have like 4 or 5 guys here unlocking it. You're going to be able to do that. So that's what's happening here, is that your body, in a person who's got type 2 diabetes, the insulin that their body is making is just not enough. Even if you're on these oral medications that's trying to make more insulin, it's just not enough. So they're going to have to give themselves insulin to get it to that much. All right? And sometimes they'll have to get all 3 over here. So here's a little tip for you guys. If someone is obese and they're diabetic and they're on insulin, remember, the more adipose tissue you got, the more gunk you got in that keyhole. So and they're on insulin. So I hold this to water. If someone's obese who's on insulin because of diabetes, I guarantee that if they lose 50 to 60 pounds, all right, they will be off of insulin. Okay? I mean, because of all the fat, that's what's doing that. But if they'll be a diabetic, those people will have to probably take oral medication or diet, whichever. But I will guarantee you lose the weight, they will be off of the insulin. The insulin is because you have so much weight, so much of the adipose tissue that's putting those receptors not working. Okay? Does that make sense? Right? Okay.